afternoon. I'm Jana Martin, Chief Executive Officer of the American Insurance Trust, known to most of you simply as the Trust. We are delighted that you're able to join us virtually today for the next webinar in our virtual webinar series. The Trust is pleased to be able to offer this informative content free of charge to our policyholders. Most of you are likely familiar with our risk management consultation service, the Advocate 800 program. It's one of our many benefits which our policyholders receive through the Trust. 3 of our advocates are with us today, Drs. Amanda Zellahusky, Daniel Taub, and Liesl Bryant. In the interest of time, we've placed their bios on a slide. This virtual webinar will earn you 1 CE credit. This can be combined with 5 other risk management credits to save up to 15% on your trust-sponsored professional liability insurance policy. Please remember to submit your CE certificates with your policy renewal. Again, I hope everyone learns a lot over the next hour. Please join me in welcoming our esteemed presenters.
Thank you, Jana. And before we get going, I just want to note we're actually adding in a couple things from extra questions that we didn't get to on a prior webinar, and also several that we've had a lot of calls on. So we're going to add those in just to start. We're going to begin with those. I think there's 3 or 4 questions. We'll start with those so we can be sure to address that and get that information to you guys. Definitely feel free to write in your questions in the Q&A, like Jana said, because we're absolutely going to be taking live questions that you write in as well. So just wanted to give you guys a heads up on that. And with that, we'll go ahead and start. The first one is one that we're getting lots of questions on, and there's sort of different pieces to it. But generally, the idea here, and I know, Dan, you spoke about this in one of the prior webinars, so I'm going to let you start. But the question is, can you review sort of the basic things to consider with regard to possible reopening of in-person services? Things like whether and when to do so, what kind of precautions to put in place, and what kind of liability there might be. So Dan, I'll let you go.
Okay, thanks, Liesl. So good question, and in one way this is a tough one because as all of you know, the target is moving. None of us really know what will evolve. But under these circumstances, what we've been recommending is that, and saying is that as we transition back to in-person services, it will add some degree of risk at this point. It's not overwhelming. It does not prohibit your ability or our ability to provide services. But it does mean that if technology, if teletherapy or telepsychology is available for you, then it may be wise to still lean on it for a while as we transition back into in-person services. Now, just a couple of notes, Liesl, about that we are not, and I know you know this, and Amanda, you know this, we're not intending here to give you a statement about a standard of care. We are intending to provide you with information about risk management. Frankly, who knows what the standard of care is going to be? And that's up to courts and official organizations. Second, this is not a statement about your coverage. Our affiliated insurance company, the liability carrier, is saying that it will cover when there are allegations of, that is for defense, of allegations of that someone caught COVID in our office, as hard as that may be to prove. These are going to be decisions by each one of us, okay? So we're very mindful of that. Now, that being said, there are 6 steps, hold up my hands here with 6 fingers, 6 steps that we encourage you all to consider in the process of reopening. The first is going to be engage in frequent low threshold consultations, which means when you have questions, feel really comfortable reaching out and asking valued colleagues, or us if you happen to be trust members, and I think most of you are. The second is engage in an explicit analysis, ethical and risk analysis. And the ethical analysis here is doing no harm. It's not so easy to determine, are we harming or not by in-person versus teletherapy, but really think it through and document a well-reasoned both plan, but also decision about particular clients, okay? And that includes, that's the third point of documenting the articulated reasoning and conclusions. The fourth one is, it's going to be very important for all of us to develop a protocol for reentry that, excuse me, that basically builds in your safety planning. And I will be talking about that in just a few moments. But the safety planning are things that we're all hearing a lot about, you know, wearing masks, hand sterilizing, and that sort of thing. But having a document that you share with your patients and with office mates and staff, as well as having it posted on your website if you happen to have one. And then the fifth point is going to be having an informed consent form, okay? And we have a model that I think you may find useful. And let me show you where you can find this. So I'm going to go in and share the screen, Liesl, and I'm hoping everybody can see it. And this is the trustinsurance.com website. You start here. You'll notice it says Advocate 800 program. And then what you do is just scroll down the page just a little bit. And you're going to see, click here for COVID-19 guidance and resources. When you do that, that'll take you and land you on the page for COVID-19. And what you're going to see on the right-hand side are a list of resources, okay? If you scroll down to the bottom of that, you will see our sample informed consent form for returning to in-person psychological services. So trustinsurance.com, and then moving from there to the COVID-19 resources, and then scroll down the page a bit. Very helpful, very important to have an informed consent form. Now, please be aware, we can't transfer liability or responsibility or risk to the patients, okay? These are not forms that are going to say, oh, you're agreeing to come in person, well, you're waiving liability. Our states pretty much uniformly frown on professionals doing that kind of thing. That being said, it's very helpful to reduce surprises and also to make sure that folks understand the risks. And we can't assume that they do. The sixth in these 6 steps is to make sure you're monitoring ongoingly the information that's being published by federal, state, local governmental organizations like public health, CDC, and professional organizations for guidance. That's particularly relevant if there's a spike or a surge in your community. You may find that you're going to want to and will have some backing for going back to telehealth for a time until things begin to settle down. Now, there are a number of factors, and I'm going to give you 8 factors briefly, to consider in making these decisions. So when you use these 6 steps, these factors will integrate into your decision-making process. The first is, be sure to document, and I'm thinking of this as kind of a particularized or an individualized documentation of what it is that why it is that you're determining in-person is appropriate for this particular patient. And it's the best, or actually the best way to provide care. And the reason for doing that
Uh-oh, we might have lost Dan. I think he may come back, but Amanda, do you want to jump in on any of those? You may not. I know you don't have the same list, but.
Yes, I was waiting with bated breath for number 7.
Well, I think for what it's worth, I think he's going off the list that's in our in-person statement on the website. So for those of you, if you go to that website and in that resource list that he showed you on the screen share, it's the trust statement on in-person services, and it's dated May 7th. So that has all of the lists that he's talking about in there, the things to consider. And then there's places in your informed consent, just like Dan talked about the informed consent document, where you can document some of the things too that he's saying are important to document. So like the reason why you're going to meet with this patient, those kinds of things. Amanda, anything else?
Yeah, and I think he was just wrapping up with that documentation piece, right? That it's very important to be making these decisions on a case-by-case basis, you know, which is, I think, a theme you'll hear us talk about a lot today, and documenting the rationale for returning. Oh, he's back.
I am. I have no idea what happened, but thanks for your patience. Where did you leave off?
I was trying to continue number 6. I didn't want to steal your thunder of number 7, Dan. We were all waiting, holding our breath.
Okay, so If number 6, you were talking about if you've been deemed an essential worker.
I was just picking up on the documentation pieces you were talking about with that.
Okay,
So
great.
go from there.
Okay,
Yeah.
great. I did talk about determination, right? And also each patient's category and risk categories. And then the other one is, if it's available, this is the 4th point, the infection rates and the fatality rates and testing rates in your community. Some communities don't have that, okay? Others will. If you get the data, it will help make decisions, okay? That's essentially the basic idea. The 5th point is the degree to which your local jurisdiction has ended or is phasing in states of emergency and shelter in place. If they're saying we're ready and everybody can go back to work, it doesn't mean that we do so without attention to these factors, but it does mean that there's less of a concern in your jurisdiction about COVID at this point. And then, of course, we're being deemed essential workers and critical workers in many jurisdictions. If there still is a restriction and still is emergency in place, then looking at, well, am I an essential worker? And if so, do these risk factors line up so that I can go back in and do personal work? Some communities are offering legal immunities to frontline providers or even healthcare providers. Illinois had extended theirs, for example, to people treating COVID. So it depends on your jurisdiction, but that will help too, because that will reduce the likelihood of risk. And then the last point, and Amanda, thanks for picking up for me. I must have done something to offend the technology gods, I guess. But the last point is that be aware of and really thoughtful about the practical capacity that you have as a practitioner to abide by the CDC protocol. So for example, hand washing, wearing of masks, whether you can do in your office physical distancing. In some offices, it's a lot harder than others. Obviously, all of us can say no handshaking, no physical contact. We can also do things like having our patients agree to cancel if they're having any type of symptoms and if they've been exposed recently. Waiting room arrangements, so there aren't folks sitting close together. Payment methods that don't require physical contact with something, and then having cleaning routines. So we all understand on our team, and I think in much of the United States, but in our team, these are difficult decisions, okay? Being familiar with helpful resources, like some of the ones that I've referred to, consulting and documenting, just like they always are with risk management, are excellent strategies. And we want you to take advantage of the advocacy line if you've got particular questions, okay?
Great. And just because there are questions coming in, I'm going to toss in one that's already in the Q&A, because I know there's a lot of this, but can you speak to how liable can a state hold a practitioner for a client becoming infected with COVID if it happened, quote unquote, if it happens in their office, which is, I know is approved, but I think if you can give a response to that, that would help a lot of folks.
So this will, 2 things. One will, if the state does not grant immunity, then it goes into possibly a malpractice case. And then it's going to be up to a jury and a judge and the attorneys who try to negotiate it. Do I think the risks are high? No, but I do think they're present. They're just somewhat elevated. If the state licensing board, which is where I see there to be more likely to be risks, is a particularly restrictive one, or one that's very cautious, they may see are not following, for example, the CDC guidelines as evidence of are not being adequately careful. And then it could affect our licenses. We could be disciplined potentially.
Great.
And could you just run through, it looks like people cut out at different times for when they lost you. Could you just review the 8 factors again?
Sure, I'll do it very quickly, okay?
I'll do on that because I think let's just refer them to the document for
Okay.
Oh, sure.
A ton of questions coming in. So sorry to cut you off there, but
That's okay.
so it's all, Dan, correct me if I'm wrong, but isn't it in those factors that you outlined, isn't it in the in-person statement that's on our website?
Yes, in that same column that we looked at to find the informed consent form.
Great.
Perfect.
Thanks. Okay, so another question, and we're getting a lot of these also in the Q&A, so hopefully this will touch on that as well, but what to do when an office mate or other businesses in shared office buildings are not following proper safety protocols, and thus putting me or my own patients at increased risk, even though I may be following protocols. Amanda, do you want to start with that?
Sure. Yes, we have been getting this question in various forms. So I'll try to talk about some generalities and then maybe some specific considerations. For some people, it's been, shared office space, other clinicians in that shared office space. For other folks, they've had concerns about if you're in a larger office building and maybe some of the folks who are renting other complete office spaces within that building are not following protocols. So I know that has varied for many of you in different ways. So what I'd say first is to make sure that you know what the current requirements are for your jurisdiction. A lot of those things Dan started to talk about, who is essential and what are the safety protocols? What do the shelter in place or stay-at-home orders look like? If you're in a state that has started to phase back in various iterations, you need to know what that phase back plan looks like and what that means for you and your particular practice. So you need to know what the requirements are before you, think about talking with somebody else who may or may not be following those, because sometimes we're maybe doing more than what is legally required or has been issued, and know the difference between what are requirements versus guidelines. And so just be aware of what those requirements look like in your jurisdiction, because it varies. And I found this in my own area. It can vary from county to county and from city to city, even if the state might have different orders in place. So just be aware of what those look like. And then I would say, of course, the first step, which our ethics code talks about, many state policies issued by licensing boards talk about trying to talk with those colleagues first. And so even before you're back at work or phasing back into in-person services, it's a good idea to be proactive. Talk with office mates, talk with other businesses that share that office space, with your practice, around what will our plan look like. It's always helpful when we can have sort of a consistent rollout plan and consistent messaging to our various customers or clients. So if it is possible to be proactive and initiate some of those conversations, maybe your landlord or building owner is already doing that for you, to issue guidance to all of the folks who rent space, to just try to think about what can we get some consensus beforehand around what our policies and procedures will look like, and even maybe discussing how should we handle it if somebody is doing something that makes us uncomfortable or is putting our clients at increased risk. So try to have those conversations ahead of time if you can, before it becomes an issue, right? Where you feel like somebody is not following proper safety protocols. And then, of course, if that's not working, or if you're already back, in delivering in-person services, talk with those folks, try to approach them and say, maybe I'm a little confused. Here's what we understood to be the protocol that we need to follow. How are you doing it in your practice? Can we talk about what that looks like? Maybe you have patients that are at increased risk, and so that's how you kind of come at it, that we're really concerned, because though this may not be a concern for your business, it really is for ours. So confronting that person, and confront, I use as a strong word, right? But trying to talk with that person or that business first is usually what's recommended, but recognizing that, we have different considerations based on who our clientele might be. And then also communication with your own patients. Be very clear about what your safety protocol is going to be. Here are the steps I am going to follow. Here are the steps we need you to follow. Being very clear in your communication around what that will look like, what they can expect. Perhaps you've decided to have them enter a different door of your office building because you're concerned about a business maybe in the front of the building that isn't following proper safety protocols. So what steps are you in your practice taking to reduce the risk of exposure for everyone? And be really clear about what that plan looks like. You can always do more than is required. It's just that, it's tricky when you're trying to require more than is required by law of other businesses, just because you feel that's necessary for your own business. If things are really extreme, that people, other businesses or office mates are not following any of the required safety protocols or guidelines issued in your jurisdiction, you can take the steps of, of course, contacting your landlord or building owner. You can contact the Department of Public Health in your area to, ask them for guidance around, are they doing investigations, or can they issue some sort of letter or warning, or something like that anonymously, even if you're worried about conflict. So those are some steps you can take. And of course, you can also, in some cases, step back into telehealth if necessary, because you may feel like after analyzing this, I just can't put my clients at risk given, these fellow office mates not following protocols. So it may be that that's a step you have to take as well. So those are some initial considerations.
Great. Terrific. Thank you. We have just two more that we're going to do before we start taking the live questions, and I see the live ones are pouring in. So, but I do think some of them tap on this. So the third one, Dan, I'm going to let you start on this with the idea of the issues concern cross-jurisdictional practice, right? So is it okay to either start treatment or to continue treatment with a current client who, say, is a college student and who is maybe in a different state than I am or that I'm licensed in, and maybe they may be there for an extended period of time, right? And they may not come back to the state where we're licensed even as long as till January 2021, right? If the fall semester remains online. So can you give some guidance for folks, like what kinds of things do they need to be thinking about there, and how can they help to make those decisions?
Sure. Most of you are aware that states take the position that when a client is located in that state, then you're practicing there. There are some exceptions. Maryland, for example, says it's either the client or the therapist. So I could be seeing somebody out of state, not licensed in Maryland, licensed in, say, Virginia, and they could argue that I was actually practicing in their state. Most states take the position it's where the client is located. Notice the word I'm using, not resides, located, because there are lots of college students, for example, who develop their residency in their current state so they can perhaps take advantage of local or resident rates for a university. It's where they actually are. And during COVID, most, or many states, I should say, have loosened their rules, but it's a patchwork. South Carolina, North Carolina are saying if it's continuing care, it's permissible with some restrictions, for example, in North Carolina, but they don't either allow non-licensed people to provide the service like a postdoc or a pre-doc intern, and neither say that new services are accepted under their rules. Other states like New Jersey have been providing temporary licenses with an application online and doing very quick turnaround, literally, a few hours. And still others are using their standard prior to COVID approaches. So the basic idea is that it's where the client is located. It's very important to know what state your client is located in for a number of reasons. Now, if it's continuing care, Liesl, then it's more ethically defensible because you could make a good argument for welfare of client and continuity of care. But there are some other considerations, even with the welfare of the client or patient. One is, and a very central one, I think, is the suitability of that client or patient for distance services across state lines, particularly if it's a state that isn't granting jurisdiction or granting temporary licensure in practice, right? So people with significant fragile eating disorders, cluster B symptoms or diagnoses, substance abusing clients, they may be clients where a referral is important, even if there are continuity of care issues, partly because if something goes awry, the in-state remote provider is going to be safer than the out-of-state remote provider. Also, thinking about, and you mentioned this in your question, Liesl, thinking about, is it likely that these services are going to be for transferring of care, or are they going to be ongoing? And we don't really know at this point, but as regards students, and this is, truly an intentional pun, but not necessarily funny. Universities are all over the map. The university system in California has said we're only doing telehealth in the fall. But if you go around the country, and even in California, you're going to find that some private institutions and public institutions are starting up again in August, or at least they're planning to. So you have to be attentive to whether it looks to be a shorter term issue. And then the last thing, and this echoes what I was saying earlier, and also, Amanda, what you were talking about earlier, is not only it's actually slightly different, excuse me, I went off on a different track there, but it's also about Do you understand and have access to possible crisis or needed crisis services in those jurisdictions? So if you have a practice in State College, Pennsylvania, and your client returns to Chicago, you call 911 in State College, you're not getting Chicago, and they're not going to transfer your call. So you have to become aware of, if you're going to go do this kind of cross-jurisdictional work, about how to locate emergency services. Those are some initial thoughts, Lisa.
Great. Thank you. Amanda, anything you want to add before we?
Yeah, I was just thinking about, yeah, I agree, Dan. It's a lot of it up in the air. Universities and colleges are handling this in lots of different ways. And so I think we have to continue to be flexible, and it's hard for all of us as clinicians to make decisions with those kinds of cases for much longer than, say, a month or two at a time. And so in these cases, I think, a lot of times we recommend that those are some of the contingencies you're building into continuing to provide telehealth services right now, to say, you know what, we're going to reevaluate this, each month, and try to figure out, number one, what's going on with temporary practice provisions and stay-at-home orders, whether it seems likely that this is going to go on longer than we originally thought, like you may not return to campus until January, as you said, Liesl. So I think thinking about things in making short-term decisions can help and have the client aware of, we're not deciding for the next 6 months or 9 months. We're just going to make a decision each month and go back and reevaluate. Is this still clinically appropriate? Is this meeting the need? Can I do this, legally in terms of my license at this point? You may just have to keep reevaluating.
Yeah, good point.
That's great. Yeah. And what I like about that too, Amanda, is it does allow for flexibility, right? Because things on the ground are changing and we don't know what's going to happen in a month or two. And I'll just add the piece that we talk about a lot, but documenting that decision. So at each of those points where you're reevaluating it and you're talking with a client, being sure that gets documented in the record.
Yeah.
That's clear as well. Great. Okay, so a slight change in topics, but still related to this in-person. Do we go back to in-person or not? The question is it okay and or safer to offer in-person services outside, such as in a park, walking near the office, those kinds of things, as an alternative to indoor in-person services? And if so, what risks should practitioners consider when thinking about doing things outdoors? Amanda, do you want to start there?
Sure. And yes, we are getting this question a lot. I think that a lot of folks, it's coming from some different clinical perspectives and situations. And so I've been getting this question a lot, particularly from people who do primarily psychological testing or assessment, because there are just simply things you cannot do remotely. And so, but it's certainly coming up for people providing treatment as well. So a couple thoughts about that are, again, to try to think about each case differently or individually. We tend to talk about, or I've heard a lot of clinicians talk about it as, I'm either returning to in-person services or I'm not, making these sort of global decisions or feeling pressure to make a global decision across your practice, as opposed to making case-by-case decisions. So for some assessments, I'll stick with that, scenario for a second. There is a lot you can do remotely. There may be elements of that assessment that you can't, but there are some parts like the interviews, talking to collaterals, gathering background data, those kinds of things that if you sort of think about chunking the evaluation or the components of it into different aspects, then it's a little easier to make decisions around, well, what do I absolutely have to do in person versus what are some things I can still do remotely? And similarly in treatment, right? So thinking about what is necessary right away, in person versus what might I still be able to do some parts of, or do a hybrid approach, of not meeting in person for every session. So think about each case differently. Think about the components of what you need to do in those cases in separate elements as well. Because there are considerations, of course. If you start to think about delivering services outside, and I understand why people are thinking about that, right? What if we're in open air and, there's less risk of transmitting, but there's other considerations there, and certainly pros and cons, and we want you to think about some of how that might challenge the structure of the relationship, things like privacy and confidentiality, which I'll talk about. So some considerations there in addition. Again, as you're separating out parts of what you're doing, do only what's necessary right now in person. If there are things that you can still do remotely to minimize risk, then great. Informed consent is a huge piece of this. Even before COVID, we would be talking about that. If you were wanting to do maybe some unorthodox approaches, or maybe you're somebody who does exposure therapy who needs to be, out in different environments as part of the treatment. There are additional elements to your informed consent we would want you to add in there. Think through, talk about with the client. What are you comfortable with? How are we going to handle this situation, if we are out in public and A, B, C, or D happens? What does that worst case scenario look like that increases sort of risks and liabilities there? So considering some of those scenarios that can happen and adding that into the informed consent conversation and agreement that you come to with the client. Here are the things that we're going to try to do outside or in person in creative ways, and so related to that, I'd encourage you to get creative. So I understand, again, people wanting to try to do some of these things outside, but remembering that, especially if you're in a small community and people walk by and recognize one or both of you and ask, oh, how do you know each other? There are those kinds of things to think about, even if you're trying to set a somewhat private area, maybe in a courtyard of your office building or something like that. Is there somebody who has a window open in another office that might overhear some of your conversation? Might your client be, sort of inhibiting some of the things they might tell you because they're worried about who would hear, things that they're disclosing? So what sort of sensitive information are you maybe asking about that would be more appropriate for a remote conversation, a telehealth type conversation, and then saving, again, maybe some of the neuropsych battery elements that you have to do in person. You have to observe what people are doing, how they're manipulating an object or writing or something like that. Save those things for what you do in person versus the more sensitive conversations. Are there other ways to do sort of alternative social distancing options? So things like you can still wear a mask. And I know a number of folks have been asking about, what if I have to see their mouth, their lips, I have to read lips. I've seen people getting really creative in how they're making masks with clear, shields so that you can read lips. So things like that. Maybe you're having somebody still come to your office, but do testing in a separate room in your office building, but through Skype or FaceTime or a video chat platform. So you're still controlling the environment they're in, but you're not sharing a small enclosed space. So I encourage you to get creative with how you can still, meet these safety protocols, but still meet the needs of the types of clinical services you're providing. Because related to that is also, of course, for those of you who do assessment, the standardization of how we administer assessment tools is a big consideration here. And I know that's been a concern for many of us. And well, I can't do this assessment, via telepsychology because it's going to completely change how I administer the assessment, or I can't ensure things like the individual has complete privacy when answering these questions, or they are in a distraction-free environment. So I think there's something to be said about controlling as much as you can of those variables, right? But still trying to think about how can I, maintain these safety protocols and social distancing. And of course, whatever you decide to do in consultation with the client might even say, it's fine. I don't mind if we sit outside. We still have an obligation to be trying to protect privacy and confidentiality as much as we can. And so document the decisions that you've made, that this was in consultation with the client. Here's what we agreed to. Here's how I'm still trying to minimize the potential risks that I recognize are there. And just make sure your documentation is really clear. So those are some initial things. I don't know if either of you have other things to add.
No, Amanda, you've covered what I think is important. I think you've hit the highlights. Yeah.
Yeah, same here. So we will jump because more are coming in. We're going to jump to some of the questions on supervision. So Dan, I'll start with you with the first one. Any thoughts about the ethics of supervising live through Zoom sessions?
I'm sorry, could you say that again?
Yeah, any thoughts about the ethics of supervising live through Zoom sessions?
Mm-hmm. So they're very similar to, at one level, very similar to doing services for clients, privacy issues, feasibility, the issues of the person who's a supervisee and where they are, where the supervisor happens to be. The key concerns I think that I would have would be, does the state say that you can count those hours if it's going to be supervision for predoctoral or postdoctoral internship? That's really what the key is. And many states have loosened the rules and made official statements, but there are some that haven't. So one thing that I think all of us have been encouraging folks to do is to be in touch with your state board and find out, now that we're in shelter in place, or now maybe that the emergency rules have been rescinded or the declarations have been rescinded, may we go back to in-person? Are we required to? Or can we still do remote if they indeed granted permission? But it's very important to check. Like therapy, there are going to be limitations on a supervision via Zoom. But as most of us have been finding out, what we're trying to do is the best we can under really difficult circumstances. And where there are regulatory kind of permissions or relaxation of enforcement, then one can feel, I think, more comfortable saying, all right, this is a reasonable step to take. I'm going to make one more comment and then certainly feel free to chime in, Lisa or Amanda. Even though the Department of Health and Human Services has relaxed, it says that is the federal government has relaxed its enforcement for the period of this emergency of requirements that the video chat platforms be secure and HIPAA compliant. We are still encouraging you to use a HIPAA compliant platform, and that would go for supervision too, because there's protected health information being communicated. So I'd be very mindful of the platforms you're using. Obviously, if there are significant problems, if you can't use one of the secure platforms, then you want to articulate and document why.
Yeah. And I'll just add to that last thing, if you are using a non-secure platform, really important to also communicate that to your client and get, in essence, have informed consent with your client so that they understand the security issues, aside from whether, the Office of Civil Rights allows it or not. Amanda, anything you want to add there?
Yeah, I was just, and I think maybe it was related to my understanding of the question too, is I would just say there's a difference also in considerations between conducting live supervision, meaning, sorry, maybe I shouldn't call it live supervision, conducting supervision via telehealth, right? As Dan was talking about, those regulations, as distinct from live supervision, meaning I'm zooming into a session with my supervisee and his or her client. And so I think those are different analyses, right? So just that they both carry with them different considerations, particularly if it's live supervision, zooming in with a client, all those considerations, Dan mentioned, but just this is not something we've ever done before. I've never sat in a session. It may be that much tougher to justify this or make sure everybody feels comfortable with me now, video, participating via some sort of video platforms, because people are already uncomfortable in lots of ways with these, remote services.
Right.
If I can just say one more thing, and then I know we have lots of questions. So in some ways, Amanda, that's such an interesting question, and I like how you heard this. I didn't hear it exactly the same way, the question. But it reminds me of the days when we were doing reflecting teams, where you would have professionals behind a mirror, sometimes a whole group, watching a session. So I think with appropriate and adequate informed consent, if we take the perspective that you were taking, which I really like, we could actually, I don't know that I would say it's impermissible. I just think it would be something we'd have to have our colleagues and we as supervisors think through and make sure that the clients and patients are agreeing and that the supervisee knows how to do it and all of the pieces of the puzzle are in place.
Right. Yeah, I agree.
Right. So here's a related question with Practicum students. Can you give us some guidelines for the responsibility we have to our advanced Practicum students in an inpatient psych setting, including accommodations in the time of COVID? Amanda, do you want to start on that?
Can you read it again? I'm not sure I understand the question.
I think it's really asking in terms of what guidelines for responsibility. If you're in an inpatient psych setting and you have Practicum students, are there responsibilities in COVID in terms of keeping them safe, requiring them to come in or not, those kinds of things, anything including accommodations, that kind of thing.
I see. Yeah, I think this is like in any employment context, right? Employers are struggling with this in so many different spheres. And then again, with the differing regulations and stay-at-home orders and who's an essential worker and who's not, I think some of it depends on who is deemed an essential worker, and are interns, Practicum students, in that particular hospital setting, are they deemed essential workers? Can you require them to be there? What do those accommodations look like? Certainly, I supervise graduate students and teach graduate students, and this is a struggle we've had, but tried to work really in partnership with each site supervisor. How can we come together to get the students' training hours needs met, but with the understanding that they present different health issues and risks. And, just like we talked about on a case-by-case basis for clients, I think sometimes for our trainees, we have to think about that too. And I also think that trainees understand that for the supervisor, I mean, first and foremost, we have to be thinking about patient care. And so I have to take care of that first, right? But then, what are the considerations around whether I can legally require you to be here? And if you're not an essential worker, then that may, that may be in question. And then that's separate from, as an employee, if you will, separate from academic requirements, that we also recognize that students are at risk of not completing hours and not completing, getting credits that they need within certain timeframes. So I think as much as everybody can collaborate is really going to help with that. And just talk with your practicum students. What are the concerns that you have? Here are the safety protocols we're implementing. Here's how we're going to try to keep everybody safe. How do you feel about that? And interestingly, for some of my students, I think it's been the opposite, that they really want to be back at work. And their particular, supervisors are saying, I'm really worried about your safety and I don't feel comfortable with you coming back yet. And so I think they're just as collaborative as everybody can be, the academic institution, the clinical site, and the student, the better those conversations and agreements are going to go.
Yeah.
Great. Dan, any addition there? Or?
Yeah, just a footnote on the reasonable accommodations. The person who asked the question probably knows that reasonable accommodations for people with disabilities under the ADAA are negotiated. And because the practicum student is in a very vulnerable position, I think it makes some sense for supervisors to, while we're putting this, as Amanda put it very well, we're keeping our patient care first, but that we have to also be aware that supervisees are vulnerable. And they may be very motivated, even, for example, if they have a heart condition and they say, oh, I'll be fine. Mm-hmm. That's where I think it's going to become important for supervisors to say, I don't know if that's the case. And even if it may appear to be somewhat paternal or maternal, that we consider the bargaining position in this reasonable accommodation conversation and not just assume that it's okay.
Yeah, that's a great point. They're very motivated to be done. So just let me be done. Yes.
Right.
That's great. Thank you, Dan. So this is actually another question we're getting a lot, I know, on calls as well. So it's probably good to speak to a bit. But and of course, the question asker here acknowledges that there are many site-specific factors. But if you're in a practice that the main plan is to do most therapy via telehealth, and they're trying to decide when do they do in-person versus telehealth, they say what would be the clinical factors and/or criteria that might warrant an in-person session. So can you give them, I guess, Amanda, we'll start with you on this. Can you give sort of just like a couple of factors or several factors that they can think about to guide that decision in terms of what might make sense and why it might warrant being in person versus continuing to do it on telehealth?
Okay. Yeah, I mean, I think it all relates to that sort of clinical appropriateness and then the risk-benefit analysis Dan was talking about, right? So what are who is pushing for the return to in-person services? Is it the client? And if so, explore that clinically. Like, what about it? Why is that? So I think that's a piece to look at. Who's pushing it? Is it me, the clinician, or is it the client? And then, what's underneath that? It may be that that's more just an emotional issue. I miss you. There's an attachment piece. I miss seeing people. Like, there could just be a lot of clinically rich data there to wrestle with that actually has nothing to do with a physical need or something else to return to in-person services. So I think exploring that would be key. I also think the client's level of risk is a piece there. Is this a client that historically I've really needed to be tracking affect and how that's matching what they're saying, and I'm just not getting that in our ability. I just can't do that in the same way over telepsych. And because, say, this is somebody with a pretty significant history of suicidal ideation, and my need to be tracking how their affect is mismatching what they're saying, there may be reasons like that in terms of assessing risk and just their clinical levels are elevated in terms of symptomatology that I would feel more comfortable assessing in person, so maybe considerations like that. You also need to consider your own risk and level of comfort with this. And I think this is something we don't tend to be really great at, right? We're thinking about what's in the best interest of the client, as well we should. But we neglect to think about, do I have health risks or reasons or loved ones that I'm coming home to with increased, risks for exposure? And so am I comfortable returning to in-person services? Or are there reasons that it just doesn't make sense for me right now, in which case I'm not as impactful as a clinician if I'm so distracted by my own safety here. So I think those are some of the things I'd be thinking about. I'm sure you both have more to add.
Yeah, just a couple of things, Amanda. One of them is I'd also be attending to, is the client not benefiting from the service that's remote? Or are they decompensating? Those seem to be really two important factors. The other thing is very practical. And we had an example today, right? Even though I supposedly have extremely speedy and very good connections, are you having lots of technological disruptions so the sessions are not flowing well? Are they in a part of your community or perhaps in a rural area where they get no reception or very little? And then I think you can make a better argument for this person, in combination with the factors that you were mentioning, Amanda, really should be seen in person because you're not getting the information and having a continuity of care that you ordinarily would.
Yeah.
Right. And I think, one of the ways this has come up for a lot in the calls I've taken are actually the clinician is feeling pushed. So, Amanda, I love how you say, like, who's asking? And, a lot of the times the clinician feels like, well, it's what the client wants, therefore I need to do that. And so I want to just sort of give permission that actually we don't have to do that. Now, of course, and I love, Amanda, what you said about, look at what's clinically under that. Like, that's so valuable. And maybe you do decide based on what is, that clinical discussion that, yes, it's important to go in, but maybe you also decide that, you just work with that clinically and you don't go in person, right? There are lots of times that people, that our clients are asking us for things that they want and prefer that we end up saying no to. So I think it's important to feel sort of flexibility and the ability to say both, yes, let's meet in person, and to say, no, let's not. So I think just thinking about all of those things that both you and Dan and Amanda have said.
I had just one other thought listening to you both, if we have time, Liesl, and that is thinking about clients for whom this just isn't working because of their home environments, right? Mm-hmm. So children that you aren't able to talk to because you're always worried that parents are right behind or in the next room, or, individuals who maybe are experiencing domestic violence, or you have worries about that. Like, so just thinking about this, telehealth isn't working because I'm so worried about this person's ability to truly be forthcoming, or our dynamic has shifted so much. And that tells me that they just don't feel safe in this environment to do the work that we're used to doing together. Or I can't adequately assess that because I'm really worried about their ability to have privacy right now.
Yeah, no, that's a great point. And I think one of the things that you guys are no doubt hearing, but in almost all of our answers today, it's really a case by case. You got to look at the case, very specific, consult, document, whatever your decisions, and do the best we can in making each decision. So, okay, here's another sort of subset of questions that have come up, but what considerations and responsibilities do we have around any contact tracing? Should either one of our patients or ourselves become infected with COVID? What kind of considerations regarding privacy and confidentiality? Dan, do you want to start to speak to that?
Sure. This is very state sensitive, by which I mean states vary considerably about whether there is a permission for psychologists to disclose information to public health when there's a contact tracing issue, right? So some states, California being a notable state in that regard, actually mirror HIPAA. And HIPAA says that we have permission to provide the information to public health. Now, even there, Liesl, it's going to be minimum necessary information, a name and a phone number or address. But do we have to disclose that they're a patient and what they're being treated for and a diagnosis? Absolutely not, okay? And it's very rare for that to happen unless we just want to say they were not here for a physical disorder, right? But that's saying what it's not rather than what it is. In the majority of states, it's much less clear. There are some states that include in their umbrellas for mandatory reporting of infections all kinds of health professionals, including, interestingly enough, veterinarians. However, the problem is that if I haven't diagnosed a patient with COVID, then it's very arguable that if I'm hearing from them that they were diagnosed, if I get contacted, I don't really have much information to provide, right? So even if I'm a mandated reporter of this, if I didn't do the diagnosis, then probably I'm not going to be mandated to report. So what this ultimately results in is that we have to really be looking at each state's rules about whether we must provide information to public health, whether our licensing boards permit that. And some licensing boards may, in fact, say, well, the law is unclear, but if you give only the minimum necessary information, given that there are significant health and life considerations, health and fatality considerations, we're not going to enforce, but it's going to be state by state. One other dimension before I stop, and that is as regards informing other patients. So let's say you get a call from a patient saying, oh, my doctor just found that I've got COVID and I'm doing okay, but I was just in your office 3 days ago, okay? We can inform our patients and our staff and our employees, other clinicians, but we don't have to say anything about the person who was ill or diagnosed being a patient. We don't have to give their name. We don't have to give any identifying information. We just say, I have reason to believe that you may have been exposed in my office, and I would encourage you to have a consultation with your physician, with your primary care physician.
Mm-hmm. Great, and I'm gonna, just because we were running short on time, so we're gonna do a bit of a speed round here. I will try to get in as many questions as we can before we end. But one question sort of is wondering about, right now there are a whole bunch of waivers in place that we've talked about, sometimes for either supervision of students or cross-jurisdictional things that are loosens restrictions. Do we need as clinicians to be worried about when those might end? And if so, how will we know that? And is that going to greatly impact the work that we're doing via telehealth? Amanda, any thoughts on how to think about that and what kind of things to keep in mind?
Sure. Yeah. And I'll just say really quickly to follow up on what Dan talked about, we actually have just added in some language in our informed consent form for returning to in-person services around contact tracing. So just check that out and, think about if that's something that's you want to include in your consent form, which we'd encourage you to do because we don't know what's going to happen with those regulations. So in terms of waivers, yes, I would say it is important for us to stay on top of those. Certainly you can call us and we can help you explore those. That's something that we recognize in the conversations we're having with you all, every day, that they're sometimes changing on a day-to-day basis as states are removing some of those waivers. Sometimes this is at the federal level and then sometimes this is at the state level. So you do need to stay on top of that because it can matter in terms of things like interjurisdictional practice or temporary practice provisions being waived, or some of those HIPAA waivers that Dan mentioned, as far as, HIPAA compliant, or I think maybe you said that, Liesl, HIPAA compliant software requirements, so many moving parts and things being waived for certain periods of time. It may be hard to figure out, well, when is that lifted? Or it seemed to be indefinite. And so looking at the nuance of the language, which may have been only until your state's emergency declaration or emergency orders are expired, that's when things kind of go back to normal. So at which point you'll then be liable for maybe what the old rules were, or if there have been new rules, passed since then. So yeah, I think it's really critical to stay on top of those waivers, but I also know it can be very overwhelming. And so, we're happy to help you navigate some of those as best as we can find information. It may be that we're directing you to a licensing board or, some other state agency to get the most updated information, but we do need to stay on top of it as best we can.
Yeah, and two things I'll just add. One good resource for that is your state psychological association, because they tend to know what the requirements are in their state, or if they don't, they can find that out. I know a lot of them right now are actually tracking that. So if you're a member or if you want to become one, you can get that kind of information from them. Dan, any thoughts you want to add?
No, I think you covered it, Amanda.
Okay. The last thing I'll just say, again, related to that flexibility, but is let your clients know that this stuff can change. So I think just bringing it up with them again in that informed consent idea, saying, look, we don't know when this waiver may change. It may change suddenly. That may mean that there'll be a change in the way we're working together, those kinds of things. So that they're, again, what, like Dan said, we want to make sure they don't get surprised, that their expectations are set. So, okay, hopefully we can get through 2 or 3 more. One question here, and this is a good one too, because this is coming up more and more, I think. How would you recommend handling patients that ask for a letter to continue to work remotely due to their anxiety over COVID-19 when their employer is asking them to return to their job site? And Dan, do you want to start with that?
Sure. This analysis is really about, do you have the data? And are you willing to step into, and is it appropriate ethically to step into a quasi-forensic role? Much like our requests for writing emotional support animal letters or doing disability letters, I think it's going to depend in part on the context, but in general, if all we have is self-report, you're working with a client, for example, or a patient who's seems to be doing pretty well and likes doing the telehealth, and then they say, I need a letter because I don't want to go back to work. I think you have to be very careful. Almost none of us as psychotherapists assess for malingering. We don't do validity scales for what people tell us. We don't have additional sources of data. So I think that's one side of the coin and an important one. But there may be a client who you're working with, a client or patient who's clearly extremely anxious, very, very frightened about being outside, has already been trying to overcome, for example, one of many possibilities, agoraphobia, and is a person with a very significant obsessive compulsive disorder, and they're now frozen. Well, you may feel like you have better data. And this is one, just like some of the other answers I think that Amanda has provided and also Lisa provided, consulting about the particulars. But I'd be cautious because I worry about it blending into a role that we really should be avoiding under the forensic guidelines and under the APA ethics code regarding multiple relationships and conflicts of interest.
Mm-hmm. Great. Amanda, any additions?
Yeah, no, I think Dan hit the highlights.
Yeah. All right. Well done. Okay. Can you discuss recommendations for providers in solo private practice in case the provider becomes ill or incapacitated? You know, in particular, I guess if they get COVID or those kinds of things, such as who will contact their clients, etc. Amanda, do you want to start?
Sure. Excellent question. Something even pre-COVID we should all be thinking about, as difficult and sometimes uncomfortable as that is. And so, yeah, absolutely. One of the things we always encourage people to have in place is a professional will. And so that would include things like designating, you know, who will be your professional representative in the case of becoming, you know, incapacitated either temporarily or, you know, permanently in some situations. And so where you're designating an individual and coming up with an agreement with them around here's what they'll have access to, you know, some people even communicate that in their informed consent to clients that in the event I am incapacitated in some way, this individual may contact you to ensure that, you know, your care can be transferred appropriately, you have access to your records, those kinds of things. So I would definitely be designating colleagues, you know, working together to come to some sort of agreement around who will cover and under what circumstances. This is for many of us, even not in solo practice, right? Making sure that, you know, others, continuity of care is what's key here. And that is the duty that we owe to our clients, is that they are able to have their care continued and hopefully not disrupted in any significant way. And of course, that they also have access to things like their records. And so we have a lot more information about that. There's a whole webinar that Dr. Joe Scropo did on retirement that actually covers quite a bit about professional wills. And so I encourage you to check that out because it includes an example in there.
Right. And on that note, thank you, Amanda. That was great. Unfortunately, we have made it through the hour. It always seems to go so quickly. And I know there are a lot of questions we did not get to. Just to let you know, we will take as many of them as we can and answer them, or we'll try to answer them on our FAQ that's on our website. So pay attention to that. It may take us a few days or a week or so to get that done, but we'll do our best. And if there's others, we may try to bring them into the next webinar again.